Well, hi everyone, it's Pete here from the Pain Toolkit, and yes, I'm back doing another interview, and I've got bumped into this guy a few months ago actually on Twitter, and we've sort of communicated a couple of times. This is Dermot McCoy, and he's over there in Australia. So good evening to you, Dermot. Dermot, can you actually introduce yourself and tell reviewers and listeners who you are and what do you do?
Sure. Pete, thank you for inviting me to speak. I think that the Pain Toolkit is a terrific initiative and one that must give confidence to the so many patients who are struggling with pain. I'm a pain specialist, or the official title is a specialist pain medicine physician, which is a protected title here in Australia and in New Zealand. So I have been living and working in Australia for the past 25 years or so. I'm in full-time private practice, in a group practice. We're multidisciplinary. We, in addition to specialists, we have rehabilitation physicians, 2 nurses, a number of psychologists, physiotherapists, and there are 3 pain programs that we run, essentially overlapping each other. We also do procedures, we also do infusions, we also do medication trials, and we're involved in research and teaching. So I live just outside of Melbourne, about 70 kilometers southwest of Melbourne, in a city called Geelong, and we're associated with the Deakin University Medical School. So that's who I am and what we do in pain practice. Yeah.
Okay, well, thanks for the intro. And I only know Geelong by watching Australian rules football. So I think
that's right.
They're playing green and yellow, don't they? Is it?
It's the Geelong Cats. They play in a striped shirt with blue and white.
Oh,
blue and white, or
what do I know?
Dark blue and white. Yeah.
Hey, listen, Dermot, it's I thought it'd be useful. We were saying before we went on the record that I get a lot of emails. I haven't even looked at the list today. Normally I get between 10 and 15 emails a day, and mainly they're from people who are they're just stuck on opioid pills and medications, etc. And I know there's a massive shift on it. I was talking to Fiona Hudson, I think was it back end of early part of this year, and she was saying
yes,
there's a big push going on there about tapering. They call it tapering, getting people off of medication and stuff. But there's not always that support there for them. I know it's big in America where it feels like they're just taking off the meds and it feels like they've got to fend for themselves, and obviously that's pretty pulled on cruelty really. But what's your thoughts on this on tapering and how perhaps self-management could be useful for them to learn?
they absolutely go hand in hand, Pete. They absolutely go hand in hand. If we go back a little bit, in the United States, the Center for Disease Control brought out a paper in 2016 suggesting that patients should not be started on opioids, and those who are started on them, consideration should be of decreasing and de-prescribing them. And of course, that precipitated many doctors just saying, I'm not doing that, we're cutting off all opioids. And it was a bit of a disaster out there, to the point that the CDC had to bring out an explanatory note in the New England Journal of Medicine saying, we did not say stop all opioids, but they had a problem with opioids, which was reflected a little bit outside the United States, but not as much as what they call the opioid epidemic. And now they're struggling with a fentanyl epidemic. The rest of the world, we did see an uptick of use of opioids across the UK and the rest of Europe, here in Australia and New Zealand to a lesser extent, and Canada, of opioids through the 1990s and into the early part of this century, because we were using them in cancer pain. And now we've come to the conclusion, and now we've come to the research shows us and tells us that really opioids long term are not great for pain for the majority of patients. There are a percentage of patients with whom they work quite well, even in very low dose or even in moderate doses, and that has to be respected.
Well,
Getting patients to realize that the opioids are of little benefit, in my view, is like performance managing an employee. Are they doing the job that they've been employed to do? Because if they're not, they're either getting in the way. In other words, the employee is standing at the door smoking fags and just talking to the employees and getting in the way, or they're actually causing side effects: nausea, vomiting, constipation, dizziness, itch, etc., and not helping pain. And then there's this phenomenon of opioid-induced hyperalgesia, where you actually get increase in pain because of the opioids. It seems to be counterintuitive, but it's a thing. If the patients come to a doctor and say, I really want to come off those opioids, that's the hardest job. In my view, that's the hardest job done. The patient is coming, the patient has the problem, they're actually handing the doctor the solution. So it's a question of just working out the dynamics and how this is going to be connected up.
Can I ask
High dose opioids, yep.
I was going to say, so if someone's interested in coming off to, because a lot of them say, well, they try to have a conversation with their prescribing, like the doctor or prescribing pain nurse doctor or whatever, but there seems to be a bit of pushback from them in some way. So how would be for a patient to, what would be the best way for a patient to start that conversation off with their prescribing doctor or healthcare professional?
Again, this goes to the point that the doctors traditionally did not get good instruction in pain, and physiotherapists, dentists, everybody. And then it tipped the other way, where we were just handing out loads of analgesia so patients wouldn't complain. We have to find the happy medium there. So the patients are often the most valuable and specialist knowledge in this equation. So if you bring the desire that you want to come off the medication to the prescriber, I would be surprised if the prescriber would say, no, I need to keep you on these medications. But if you say, well, the research has demonstrated that for musculoskeletal pain, which is my low back pain or hip pain or neck pain or whatever, opioids have not really improved my life, my function, my sleep. I'm constipated, I can't concentrate, I've got itch, etc. I want to come off them. Then what the patient should be asking, and the patient almost demanding of their healthcare practitioner, is to put in place a stepwise approach to decreasing, maybe discontinuing them completely, the opioids that they're on. And remembering that opioids plus benzodiazepines plus antidepressants, maybe alcohol involved, becomes a lethal concoction. And so we don't actually need to do any more research in this. We have the research. We have the guidelines. The guidelines in Britain are by the Faculty of Pain Medicine and the Pain Society and the National Institute for Clinical Excellence. The guidelines are all there. Here in this country, they're the TGA and the Pain Society and our Faculty of Pain Medicine have those guidelines. So we know the research is there. So it's just a question of executing that research. Unfortunately, in medicine, from research to clinic may take 17 years on average in medicine.
17 years?
17 years before the science that's developed in a lab comes to the knowledge and being executed.
Okay. Okay.
Unless it's bright and shiny and it looks, yeah. So I can understand the frustration and the anxiety and the concern that patients have when trying to decrease medications. Now, here in Australia, and particularly in Geelong, we take a very pragmatic view, so that if patients come into hospital on a big doses of opioids for an intercurrent illness, we take that opportunity to rationalize their medication, to maybe put two or three opioids into one opioid and have a plan of action for decreasing that It may take weeks, it may take months, and it may take an acceptance that coming off them completely may never happen. But if we can get them down. So, for example, when a patient presented to me almost 10 years ago, and she had an intrathecal drug delivery system or implanted pump. She was having suppositories, injections, tablets, and a patch. I actually didn't know how she was even alive. But there you go. It took me 2.5 years to get it down to a dose where we could convert it into a methadone equivalent dose. And she's still on that dose and functioning reasonably well. Now, here in Australia, we have a thing called the opioid calculator, which is free for download onto Apple and Android systems. It looks like this one. Oh, sorry. It looks like this one here. It's called the opioid calculator. It was produced by the Faculty of Pain Medicine, and it converts all the opioids into a morphine equivalent. And therefore, you can come up with some formula which are available in health systems across the UK and across Canada and the United States of how these can be decreased maybe by 5% per week, 10% per week, or whatever. High doses can be brought down very quickly to moderate doses. The moderate doses generally take a long time to come down. Yeah.
So just to wind things up, there's a lot of information there, and
yeah.
I know we're going to have we'll have to do another interview somewhere along the line.
Oh, most certainly.
Yeah, because you sound like you got a lot of knowledge going on here. But to finish up, well, what would be your take-home message to patients who are watching this, and perhaps even healthcare professionals who are watching this?
Yeah, I think if you sit down with your doctor and say, I have been on these medications for X amount of time. They are supposed to decrease their pain. It hasn't happened. They're supposed to improve my function. That hasn't happened. I want to decrease these. How are you going to help me do this? We can do this together. Essentially, short sentences, a short message, punchy message, so that the patient becomes the prime mover. And if that is the case, then the doctor should go along with it. And if they don't, you need to find another doctor.
What would be your take-home message to your healthcare professional colleagues?
That opioids have their place in medicine, in acute pain and in chronic pain. Their role in acute pain is well established. Their role in chronic pain is very small, maybe 10 to 15% of the treatment armamentarium that we use, and only for a period of time. And if the patient wants to come off them, please be an ally. Be part of that therapeutic transaction.
Dermot, thanks very much for your time this evening. Really appreciate it. Some key messages there for everyone.
Pete, I'm delighted to do it. Well done.
Yeah, thank you. Listen,
and I'll be delighted to join you again for another session. We
are definitely going to do that.
Okay.
Dermot, thanks very much. Listen, thanks for everybody for watching again. Stay tuned again for another Pain Toolkit interview. If you're someone out there who's got something interesting to say, give me just drop me a line via the website, and we'll arrange a time and date for an interview. Again, thanks very much, Dermot. Have a nice evening. Take care.
Take care. All the best.